Oh yeah, Leslie, this is why we can't afford
Thanks.
to have more than
That's fancy.
one. Okay,
Ah,
well, we're
We
live,
use
so
all
watch
the
out.
resources for this. That's all we spend money on.
It's true.
Are
Welcome
we
to the
live,
Health Tech
Kat?
Talk
Are we
Show.
live?
We we are live. All right, here's our actual crew here. Happy February 16th. Here we are.
I think so.
Melissa, how's it
Happy
going?
Cat's birthday
I was
Eve,
gonna say
everyone.
it's Kat's birthday almost, so I feel like we should be
Almost.
celebrating that.
Almost, but because we only have one Vimeo license and no one has given us enough tips, we can't afford another one. So you guys couldn't actually surprise me with like an
Nope,
incredible Photoshop birthday cake or something like that. It's a really big bummer. I don't
I just
know.
want everybody to
no
know I will be
surprises.
dropping the link to give us tips later on during the show. Support,
Oh yeah,
Amazing.
support us.
here,
We do get paid.
Melissa, I made you one. I made you one. Yeah, we currently have $250 in tips, which has not changed since last week. But
Amazing.
that's fine. That's enough to buy several bottles of red wine. So I think
Yeah,
we're
Then have
moving
a
on
yeah,
the up and up.
jar at
it's
live.
fine.
We're moving on the up and up. Okay, Melissa, you have one more big announcement for us. It's right here on the slide. What's happening next week?
Oh, so next week we are not going to have a show in preparation for Vive when we have two live at Vives at 10 and 2. So we will see you all then and have our post Vive show the following Friday.
We have an incredible lineup of party correspondents for that Friday. Lisa,
Yeah,
any
yeah.
comments?
No, I mean, this is our first real live on the scene experiment at Vive, and we are super excited. We have no idea how it's going to go. Just like we often have technical difficulties during these every Friday, almost every Friday asterisk live shows, we are probably going to have some tech difficulties too. It's going to be amazing. We have so many awesome people lined up for those. So hat tip to Melissa for getting them all on board. Amazing.
Yeah. Also, shout out to Melissa for basically handling everything. Like she handles basically all the things. So we appreciate her. We love her, and a lot of you are going to get to actually meet her next week in person. So like,
Yeah,
good for you.
she's going to be there.
Nice.
She's a real person.
I
Don't
She's a
dehumanize
am.
real
her. She's
person.
not just the person who does all of our scheduling and emails and tip jar and
I
everything
exist.
else. Community management. She really
She keeps
exists.
it alive. She keeps it alive. All right.
Yeah.
And yeah, like
Yeah.
y'all, if you actually want us to see any comments that we're supposed to address, please tag Melissa because LinkedIn
Yeah.
Live totally sucks. So please be like, I have a funny joke at Melissa Danino. Like that would be great. Okay, great. All right. All right, Melissa. Make sure it all works out. Okay, Lisa. So what even happened this week? I made an
Okay.
actual deck.
Oh my
Well,
God.
here. Well, no, no. I have a real deck to cover the things that we're probably going to talk about, but you sent through a thing that I forgot to put in this morning, late breaking news from our friend Mark Cuban, like our best friend. We're totally best friends with him,
Yeah.
about direct
Mark Cuban
contracting.
should definitely come on this show, obviously, for all kinds of reasons. But apparently, he is now, at least on Threads, positing to get into the direct contracting space outside of pharma, which is super exciting for all kinds of reasons. Mark, again, if you're listening, I assume you are, come on the show and talk about it because that is a great idea. I have some experience. We are not live. Say that
Hey,
Mark
we're
Cuban should
talking
come on
about
the show. He probably should also give us a tip. The end.
yeah. Mark Cuban. Mark Cuban is doing direct contracting now. We are here for it. Do we like direct contracting, Lisa?
I mean, is it scalable? I don't know. All I know is that we tried to test it. That program became ACO Reach, TBD on all of that. That was part of CMMI. It was called Direct Contracting, now called ACO Reach. I can totally see in our really messed up healthcare system why a big employer would be like, I'm going to pay the doctors directly. Like, screw these insurance companies. Sorry, insurance friends. I love you as well. But I can see why a big health insurance, payer like an employer would be like, I want to just pay them directly. I want to pay centers of excellence, for example, to treat my people and do it really well. I get that. But is it scalable for all of America? Find out. And Mark Cuban can argue that
What
with us when he comes on our show.
Wait, what about the Texas law? Isn't that like kind of related?
Yeah, which I'm a huge fan of actually. It never heard me say I'm a fan of a law in Texas. This one I am. It is that a person can pay the cash price, has to get the cash price, has to get it exposed to them for any kind of healthcare service, and then that has to be able to be applied to their deductible for their high deductible, usually insurance plan. And, it's like illegal in some places for a provider to give you the real cash price or to even know that. If you ask for how much something is going to cost, as you know, they're like, I don't know, we'll bill you in 90 days. And, this
Yeah.
says you have to be able to give them a cash price, be able to pay it, and importantly, it has to go against their deductible, which is very important. And I'm very supportive of that.
Yeah, I guess I'm into it. Like I'm kind of into it because I think it makes sense for patients, but I also like our friend Tom Novak was like, wah, 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 I read a study once and said it's not going to work. So we'll see. But I'm into it. I like big swings. I
Um,
like what
I
Mark
would just like
Cuban
to
is
note
doing.
that I got some real time feedback from a certain Joe Mercado that I should not be hating on ACO Reach. And to that I say, too bad. Sorry, Joe. Love you, but ACO Reach, man. Come on.
Well, ACO Reach, like I don't even know, but we did. Okay, so speaking of ACO Reach and CMMI models, Lisa, we did hear today from our dear friend Darshak that CMMI says basically everything fails. So it would be in line that you are saying that that model is also like trash. So I think that's fine. So anyway,
It's
tell us what
not
we
that
did
the
this week,
model is
Lisa.
trash. Okay, it's not that the model is trash. It's the evaluation requirements are like way too stringent for what they have to actually do. You can't really get a good sense of how well they're doing in terms of actually influencing the market and changing outcomes. But here's a new way to address health outcomes. As some people know, Kat and I were in DC and we were at the Proposers Day, which is like the launch for this new ARPA-H program, which is about paying for performance, paying specifically for specific health outcomes in a pay for performance model that is really just targeting those outcomes. And it was pretty great. It was 2 days, which is quite long. I was very against the 2 day thing, but I think that the team did a really good job. That's Darshak Sanghavi in the bottom left, who's the program manager. Up on the stage is Mark Miller from Arnold Ventures, and just a really super interesting group of people, like very diverse group coming together to figure out how they're going to respond to this major opportunity to work with ARPA-H, where it's like $15 million from ARPA-H, and then you get additional money from private investors or outcome buyers, and just really specifically targeting a couple of very important health outcomes. And that's basically open now for feedback, proposers, abstracts. It's a really cool model. So definitely check it out. And
Yeah.
you were, so I will say, Kat, not known to actually listen to the talks normally. And Kat was there. Kat is normally at the bar,
I was there.
cafe,
I
having a
was at the
party.
bar
She was
later.
there. She was listening.
I was at the bar,
That
and I
is
only
amazing.
had two smaller dinner parties, one of which was actually yours. So I actually
Yes,
listened.
yes.
I took some photos, like some of these are actually mine. Some of the ones I stole from Lisa off the internet. But no, you guys, I really want this to work. Like I really do. And you can't actually read the slide, but the four focus areas are all things that I love so much. So maternal health, OUD, AUD, and
10-year heart attack
cardiovascular
and stroke
disease.
risk.
Yeah,
Yeah.
yeah, which like is less exciting for me, but I know some people care about that. But I like 3 out of 4 like a whole lot. So check out this program, do amazing things. Here are some photos of our parties that we absolutely did throw true to form. Okay.
Yes.
Also, we just needed to include this photo. So this is
I
our
mean,
lovely friend Brendan Keeler, who like us is often wrong but never in doubt, and he totally stole our moves to Photoshop himself into dramatic
amazing.
scenes. But anyway, this guy.
Can you really say it's photoshopping though? I mean, this is not even like a, they didn't even like cut around the headshot. It's just like
Oh
literally
man,
like splashed right on there. I appreciate it though.
if I knew how to screen share, and I don't on Vimeo, we could show you the one that Leslie Kirk did this morning, photoshopping herself into the bar with Behemoth.
Beautiful.
But we'll
So
be
good.
able to talk about that in a minute. Okay. Well, anyway, Brendan Keeler is doing a webinar on March 5th or someday in March, I cannot recall, on interoperability things, and you all should go because despite us joking about each other often, he actually is like pretty smart. So go find him there.
Well, to be, I don't remember the date, but I remember the topic. It's really like all the ways that organizations can get and use and exchange claims data, and I love that. And I think it'll actually be really useful. So, Brendan, no pressure.
Yeah, no,
Make
he's
it
the
great.
best. Okay. Okay, we also learned more Q-Hens are maybe real this week. Congratulations to our friends at
Amazing.
Commonwealth and Know2. They're now like doing stuff. So I actually really like both of these organizations. I think Know2 is awesome. John Elwell is like pretty cool. And everybody loves Paul Wilder. Like, how can you not
Yeah.
love that guy?
Yeah.
I don't know. I don't know.
And they
So
had
shout out to
amazing
those guys.
cakes. Like their entire team had cakes made for Commonwealth. It was really cute. That was really
That's
sweet.
really what
Nice.
it's about at the
Nice
end of the
job.
day. So congratulations, more Q-Hins, Q-hitting, totally freaking here for it. We'll get our friend, our loyal fan, Michael Marchant on to tell us if Q-Hins are real later. Okay, also, big announcement. This happened. And we have a special guest to tell us about it today. Here we go. Leslie Kirk, CEO of
Leslie.
I
Incenna.
made it!
Oh my God, Leslie's
You
on the
I
couch.
made
We're
it,
going to
made
move this big
guys.
slide in a second. We're going to move it. But like, here's the deal. Leslie's going to tell us some amazing things and introduce herself for real because she actually is the person that makes Incenna run. But we had a big announcement. We just like threw down and donated like $1 bajillion, aka 100,000, to CancerX, which is like a real thing, and it's going to be awesome and save America. So Leslie Kirk, best friend of the show, best friend of Lisa and Kat, best
Yeah.
friend of Incenna and
Yeah. Yeah.
everyone.
I've just wanted to
Introduce
be on here for
yourself.
so
Oh
long.
my gosh,
I've been wanting to be
introduce
on
Best,
yourself.
here. I'm so
best hair.
excited.
Look, best hair on the
Oh,
talk
so,
show.
Oh my
oh,
God.
yeah.
Best hair
Oh,
on
I
the
wore
talk
this
show.
for
It is
anyone
true.
that doesn't know. I do this for Kat because she gets so excited. So this is I washed my hair this morning. This is how big it gets. It's fine. So yeah, I'm Leslie Kirk. For anyone who doesn't actually know, though, I would imagine a lot of people that watch the show do. I'm CEO and managing partner of Incenna, and I knew Kat back when we were wee cubs. We were so little
Yeah.
back in the day.
We were like 26.
Yeah. So what are we going to talk about? You want me to talk about the CancerX thing first? Talk about the partnership?
I mean, you can talk about whatever you want,
Yeah.
but like probably you should talk about cancer.
Probably, yeah. Okay, so again, I'm sure everyone who's watching this knows this already, but CancerX is part of the Reignited Cancer Moonshot, which they did Biden's did back in like April, I think, and couched under that, it's held up by Moffitt and Dime, and we are contributing $100,000 because we believe in what they're doing. So they're the goal for CancerX, which is the digital health portion of Cancer Moonshot, which is obviously supposed to and hopefully collaborate a bunch of people together, pool all the people that together to do the good things, the big things. The idea that if you put enough smart people in a room with enough money, then hopefully things will happen. And CancerX is the part that's going to work with the digital health. So we have these guys have the Moffitt, right, is doing a lot more of the accelerator portion of it, and then Dime's doing a little bit more of the data acceleration portion of it. I think is the purpose.
Yeah, basically,
right?
we're going to save America. That is exactly
Obviously.
right.
Yeah.
Leslie, tell us how this opportunity even came to us. Like, what do you even?
Well, this is why I was talking about how I'm bad at math because Kat obviously brought it to the table. I was like, hey, this seems like a good idea, and it's $100,000, and I was like, that seems like a good idea. What could
This is
wrong?
why
over here at Incenna,
Yeah.
we want to do real stuff and make big things.
in case
happen,
anyone was curious.
Yeah.
This Leslie is the best business partner because she funds all of my ideas. Basically, we're gonna save America. I'm totally here for it.
She's
We're
also
very excited
down
to be a part of this
clown, which
initiative.
I think is really important.
I mean, she's here.
The clown,
Down
which
the
is a very
clown.
important,
Oh,
very
dear.
important
Oh, dear.
aspect of her leadership.
It's true. So wait, Leslie. So tell us. So you shared a very personal story, and it's actually like kind of true. So as we shared on LinkedIn, so I founded Incenna in the way back. Yeah, it's like
It's true.
almost entirely true. I
I
forget
remember
some of the
really
pieces.
true, like
No, so like
actual reality.
Your mom really did have cancer.
no, but like some of the details about like some of the details are fuzzy, not related to your mother, but anyway. So I started Incenna, blah blah blah. Leslie came back. She'll tell you why. And then Leslie's mom's recovery is actually the reason our agency still exists because I was trying to leave to go to a company called Collective Medical where I had a great time. And I couldn't have done that unless Leslie was willing to take over the company. And it wasn't until her mom recovered that things worked out. So, and now I have the world's best boss because I came back and like she lets me spend money on things and like say, hey, how about hey Leslie, what does the bank account look like today? But Leslie, tell us the actual story because like it's like a legit story, like a real story, and it's like really affected your family.
Yeah, well, and I think it's not just why Incenna still exists and why I'm still here, but also I think it was why I was here to begin with to some degree. Because like when we started working together with Incenna, it was because it's not because of this, because it happened right after this, but I think that's why it was so easy to just make that what I was doing. So my mom was diagnosed with stage 4 non-Hodgkin's lymphoma. in 2017. And what was really weird was that I lived in Colorado, and she called me, let me know this happened. And my dad had passed a few years before that. And the relevancy of that is that my mom is unemployed. She was still kind of getting through that portion because they'd been married 30 whatever years. And you know, she's mostly blind, so she doesn't drive. And she lives in rural, tiny little town, you know, population 800 in rural North Georgia. So, you know, it was there were a lot of barriers that we had to like immediately start going through. And a couple of the financial ones, knowing that financial toxicity is something that, you know, is a big part of Cancer X, was, you know, she had, when my dad had passed, she was on his COBRA obviously for a year. And then she applied, she was too young, she was 58, so she was too young for Medicare. And she applied for Medicaid, being unemployed and disabled. But because of my dad's life insurance, she didn't qualify because she had too much cash in the bank, and that's how the world works. But then
too much money.
Yeah, too much money. That's what she was doing, rolling in dough. That was supposed to help her live for the rest of her life. And so she was on the exchange. She was on Obamacare, but because of all of her pre-existing conditions, her insurance was $1,400 a month. So that alone, before she even got diagnosed, was a big portion of this. And then also, because she lives in rural North Georgia, they don't even have rideshare up there, y'all. I don't know how many rural people are watching this. They don't even have, like to this day, do not have Ubers or Lyfts or anything in her town. So she would have to get a car service to go to even her doctor's appointment, much less have them wait around while she went through chemo and then take her home. So there's in those, I'm just trying to give like a little bit of a detail, like how intricate even little things were. And luckily, yeah, because I worked in Ensenada by that point, I had the flexibility to commute. So I was flying back for a couple weeks at a time. But as anyone and everyone knows, probably with people around that have had cancer treatments, it just takes it out of you completely. And like, you know, she couldn't, medication adherence couldn't be a thing without someone helping her. The reason we found out that it was because she had a really massive inoperable tumor burst in her stomach. And so she was on a really strict diet. But she didn't have energy to cook, much less, and they don't have delivery services up there for food. So, you know, it's like a lot of things like that. So it was a lot of layers that went into this. And so I wound up moving back and taking care of her. But I think the key points here that align with our goals with Cancer X was she's someone who didn't fall through the cracks. She, like, within the system, it was fine. She's obviously okay. And she's luckier than a lot of people. But, you know, it's only because she had me and because she had us and she had a couple lucky circumstances. But that one thing drained almost everything she had, which means that she now only has us to support her because she can't work and drive. And currently we're trying to figure out how to get her closer to, you know, like all these layers of things. And not to like oust my mother, but I also found out that she hasn't gone to any of her follow-up appointments because she's like, I can't afford them. I can't get there because, we didn't know that. We actually just found this out a handful of months ago. So anyway, that's a lot of like heavy stuff.
No, I mean,
that's a lot of layered stuff, right?
I mean, what did we learn here? We learned that have children.
I gotta go do something, guys.
Especially if you live in rural America.
My dog is going to take care of me when I get older, so I don't know what your problem is.
Me and Lisa will
take care of you.
It'll be fine.
I'll take care of you. I have a favorite. I've already told my niece which one is going to have to take care of me, so I'm working on it. Children, someone else's children, my sister's brother's children are going to take it. It's going to be fine. We got it. But the point is, this is exactly what happens, right? There are so many gaps. And the like audacious vision that everyone with cancer in America should be able to get treatment no matter what, including all the wraparound services they need to actually be able to get and actually receive that treatment. I think that should be doable, right? Like it is audacious, but it's got to be a goal, because otherwise you will have those major disparities in cancer outcomes across the country. You just have to do that.
Yeah.
Well, you know, I don't know how else you do it. You have to do it.
Well, and the thing about the good, bad, and the ugly of something like Cancer X or Cancer Moonshot or anything really that you're trying to innovate with cancer care is it's such a big thing, right? So like, how do you
Right.
focus? How do you create things that are going to really help real people? Because like, just my mom, who was luckier than most, had a lot of like weird, like she has really bad glaucoma. How is that going to interact with her cancer like all these
Right.
things that help with like care before, like treatment and diagnostics before, care during and survivorship and care after. Like there's so much. And then like anyone that has comorbidities, like how does that affect it? All of these things are so layered. And I don't know. I think about this a lot, which is I wonder if Cancer Moonshot before or just, I don't know. Like I hope we can start focusing, because even if you just solve like one thing at a time or I don't know, like, there's a lot of people out there who can innovate around cancer care.
So the good thing though, Lizzie, is that the actual things that need to happen are not that complicated. We actually don't need a ton of new biomedical innovation in this space. Like I'm sure there's always more things we can do. There's more cures, more personalized medicine. Awesome, awesome, awesome. That costs so much money, and like it will definitely help some people. But the things that matter are actually just getting people to the basic standard of care across all populations. It's really not that we have to like invent a bunch of new things right now to make a huge difference. Just getting people the care we already know is like best in class is something that has to be doable.
Right.
Like,
I mean,
I hope so.
Transportation,
I hope so.
payment, transportation. Just if you just like want to get everyone to their appointments, cool. That would be super helpful.
Or even just giving them help to support. I mean, like, listen, I love my mother, but she's, little cute little old lady in the woods, right? So like, when she's 58, she doesn't have a background in medical anything. And so when you throw all this massive amounts of financial language, medical language, drug language, I mean, that's so much for someone also going through the treatments, like just basics like that, I think we could do a lot better at.
Who has sight issues on top of that, like can't
even
pull out.
It's
totally wild.
Absolutely.
Genius.
No, I think like it is. I mean, I'm excited that so far, we're brand new to Cancer X, but so far the things that we've seen, Leslie, we're big fans of this person, Sarah Sheehan, who's leading the Financial Toxicity Project. Oh my God. We better go to dinner with her.
I haven't met her in person yet. I can't wait. I hope she's watching. I can't wait to meet you.
I don't know. We're going to have to find out. Maybe she wants a job. I don't know. But, what?
I actually have Sarah. We met Sarah at dinner, as I recall, right? That was Sarah. And we, I actually need to get Sarah a book sent, because this was, so Artists Remaking Medicine, we had Emily Peters on, she talked about the book. I was one of the writers of the book, and my entire chapter is about financial toxicity. And so I'm going to get it sent to, and I know that Insena had the book, given to all of your employees for the holidays.
I forgot to say that. Yeah. So every holiday season, I can't take credit for this because Leslie does everything hard in Insena, but she was responsible for working with Jesse Roman, our amazing ops director, on employee gifts. And every year we pick like a woman-owned business or a small business or something. And this year, everybody got a book, Artists Remaking Medicine by Emily Peters. So very exciting. It is now in my books, my little nightstand. So very exciting. So Leslie, we're basically going to save America here. Any parting words?
No, I listen. We love a low bar and giant problems, so I feel like.
Wait, did we just sell it? Did we just sell it? Is everybody like going to donate? Did we just
donate?
Yeah.
Oh my gosh.
It's amazing.
Okay. The point of this is everybody should have a business partner as amazing as Leslie Kirk, because Leslie. Yeah. I'll say one last thing. So this is a part of like a bigger initiative that we have this year. So this all started. Leslie and I get mad a lot, and I probably get madder than her, but I got real mad and I was like, no one cares about Medicaid. Rah, 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 rah. And she was like, maybe we should like do shit. And I was like, we should. So this is one of two big initiatives related to cancer care. And then we've got some other stuff coming later in the year that we are funding to make a difference instead of just like complaining all the time, which we're not into. So high five, Leslie, for being amazing. Lisa, we are back to our normal technical problems of us having to read multiple LinkedIn messages. Is so bad. Anyway, okay. All right. God bless Leslie Kirk.
Thanks, Leslie. That was fun, guys.
Awesome.
Go cure cancer. Oh my God. Okay. All right. All right. Listen, Caleb, I hope you're freaking ready, dude, because we are going to do a hard shift from curing cancer to administrative processes. How you feeling? Caleb. Ah! Yeah. How's the Great Salt
I-
Lake today? Salty?
Salty. It's no snow on the ground, so that's progress right now.
Oh, okay,
So-
all right, if you say so, yeah. All right, introduce yourself, Caleb, because listen, your PR team pitched you. We don't even know you. Like, this could all go real bad. Like, oh, no.
I know this is a big risk. And listen, my biggest goal, I want you to know, is not to be boring, okay? Because I've listened to your show and it is not boring. So I put on a flannel shirt because I'm like, what's not to speak, not boring when you wear something like this. So I just want you to know I was very thoughtful about what I wore today. So
Is that why you are in a beige office right now?
I thought about my surroundings very specifically, like what would really scream, oh, this is so interesting, right? So,
Oh my, I'm ready for it. Well, it's a good thing there's a flying eagle right next to you on the screen here. Okay, so I want to interrupt you. Tell us about yourself. Let's get to know each other.
yeah, absolutely. No, I'm excited to be here, really. And, there's a lot of things I can say. Leslie's story really made me think a little bit more deeply about what we're focused on at Vine Medical. And I guess I'll just start personally. I'm Caleb Mansell, the president of Vine Medical. Boring, right? That's, yellow.
Oh my God. Yeah.
But no, what Leslie said really hit home for me. I've got a family member right now who's been in a 10-year bout with cancer, and he's currently going through treatment. He's been in the hospital for 35 days. And we expect his medical bill will be somewhere around $400,000, which is a lot of money, right? It's not abnormal for it to get up to 7 figures, obviously, but extreme burden, not only for the patient, but it is for the hospital, right? And I feel really proud that we have a solution that really helps to streamline that process. I'll share a story that I'll kind of back it into what we really do from a feature and function standpoint. But we had a client who was actually a cancer hospital, and they had a $500,000 claim come across for one of their cancer patients. And they didn't have the appropriate documentation, but they were able to leverage the Vine Medical application to be able to find the appropriate documentation with the payer that was working on the specific claim and overturn the denial. So, I mean, you think about that in one fell swoop, being able to, one, make that burden, greatly decrease for the hospital administration, but also for that patient. Right? Specifically for that patient, that it doesn't have to come back on them or they don't have to bear that burden. Cancer is heavy enough, right? And not, so to have like another financial burden fall on them is just, it can break that family back, right? So yeah, I just wanted to mention that, like Leslie's story really, in regards to her mom and the access to care, really hit home for me in that regard.
Yeah. Yeah. So tell us about like who in healthcare should make less money.
I'm actually glad you talked about this. I was at a conference recently, and I was talking to a hospital CEO, and I asked that question to him. And
did he say it should be him? He should make less money.
Yeah, well, maybe like him specifically, probably. That's probably true. But it was interesting to talk to him about like the margins that hospitals make, right? I mean, hospitals, it's razor thin, and they're coming out of the toughest economic period they've ever been in. But then you look on the other side of the coin with payers, and they're having record profits, right? Record profits. It's crazy. And
what's in that expense sheet though? Like, what's in the balance sheet? Because we all know that you can engineer. Not to be clear, I agree. I am certain that there are tons of community hospitals that are like barely keep. I recommended on the show a podcast about the story of these critical access hospitals who are like desperately trying to stay open, can't pay the light bill, So there are definitely the haves and the have-nots in the hospital world. A lot of them are in that have-not area, but then other ones are spending lots of money on CEO salaries and fancy fountains. So the story is a little complicated. Some are really struggling.
Yeah.
and some are got a couple private jets.
Yeah. No,
And
you're
listen,
absolutely
that
right.
weighs on your margin. That razor thin margins with a private jet. It's pretty hard.
Yeah,
Jet fuel.
yeah, a little bit. No, I mean, you've got to look at it with each in every area. There's areas of all organizations that are just there's some cost centers, right? And there's
Right,
some
right.
more than cost centers. It's just absorbent, right? In how they're kind of managing and acting about it. But I think the thing that is exciting for me is going back to that claim, that difference maker, right? Being able to find the opportunities to really solve problems, especially for patients. Like when we talk about the whole healthcare system, right? It always comes back to the patient, taking care of that patient. I mean, we all have experiences, whether it's ourselves or others that we work with, that have been patients, and it's crazy what they've been through, right? And so, like, we can talk about hospital CEOs, we can talk about this payer over here, but at the end of the day, like, we've got to take care of those patients.
Well, yeah. What do you think about the one area I actually care about is primary. I mean, I care about a lot of things, obviously, but like primary care, how do we make primary care not suck, right? Because for often the patient access point is going to be primary care, especially, if you're dealing with FQHCs and you're in an underserved region, you are underserved yourself. So, what do you think about that? With all this super profit elsewhere and the nonprofit in primary care space.
Yeah, but I mean, primary care space is, to your point, it's where it all starts, right? And it's often where the burden is the most. And so I think it's important to be focused on solutions that really help primary care. And in regards to Vine Medical, we're especially focused on this. So Vine Medical is, at the highest level, is focused on taking disconnected data and connecting it where it matters most. So it's taking that data and putting it in the hands in the right time in the right place, right? And often that streams from primary care. And so highly focused on pulling that data over and across the continuum of care, right? Which often pulls into hospitals and specialty and imaging and labs and all those different things. When our clients utilize us, 50% of all those data come from disconnected places, right? They're not connected to the hospital. And so what Vine does is automatically capture that and then automatically pull it into the EHR, right? So the burden that a lot of these hospitals have is, for each piece of data, it takes them up to 5 minutes to identify the data, classify it accordingly, connect it to the right patient. Whereas our solution takes it from 5 minutes to 5 seconds, or potentially 5 seconds. And when you think about like that and how that services primary care and then also helps the patient, that gets me excited.
Yeah. Yeah. So I make fun of some of this stuff sometimes because I'm like, we're not curing cancer. We're not rescuing neonatal abstinence syndrome babies. Right. But this kind of stuff is kind of important, right? Healthcare kind of sucks. And a lot of this stuff, we were just talking about Leslie's mom, right? She's got glaucoma. So I think it was glaucoma, right? So can't read a lot of forms, and they send her a lot of forms. Is that right, Leslie? Just shout. Did I get that?
Yeah.
She said, yeah, I got that right. So simplifying some of this stuff does make a difference. I don't know if it will get her mom to actually go to her follow-up appointments that she probably should go to, but it's a little bit. So in your world, what's the biggest piece of trash process that you can cut out? What's the biggest difference you can make?
Well, I'll give you an example, and I don't know if this will be mind-blowing to you or not. For some people it is.
Maybe. We'll find out.
I was visiting with a VP of RevCycle, and she said, "Listen, we just launched a new hospital, and it took us 4 years to build." And she said her only request when they launched this new hospital, and it was only last year, was that there was no paper that existed in the hospital.
That's
and
impossible.
So she worked her
Does she have any hair left?
Yeah. No, I think you know exactly where I'm going with this, but she worked really hard so that there was no paper in the hospital. And literally the first day the hospital opened. She walks in, and after 20 or so minutes, she sees this guy hustling paper around, and she like points to somebody. He's like, "Who is this guy?" And they're like, "Oh, that's the paper courier." And they're like, "Wait, what? We pay somebody to just push papers around the hospital?" And absolutely, his job was to go to one place in the hospital, get the stack of papers, take them to the other side of the hospital, give them the papers so that they can just simply process it. And when you think about like what's in those papers, we're talking like that represents Leslie's mom's appointment with imaging, right? Or with labs or with whatever. And he's taking that over so it can literally be, given to the right person, put into the system so that it can be electronically worked to ensure that her patient care takes place.
What went wrong? Why? I mean, if she's like, that's just, I'm not, I thought you were going to say someone was walking in with like a fax machine under like a trench coat. Cause like, that'd be more realistic, right? That they told her, yeah, no paper. And then they're like, fax machine, get the fax machine in here. Like I believe that, but
maybe they got an e-fax.
E-fax. That's true. The e-fax, the real innovation in standardization. Sorry, Scott Stewie. Love you.
God bless Scott Stewie.
Right. I mean, we could talk. What are all the jokes we could share? Like, this is crazy. When do we live? We're talking about AI. You guys talked about AI like a few weeks ago. Right?
Yeah. What do you think of it? Like, if we still got a paper courier, like, listen, if there's a paper courier in this super high tech fancy hospital where there also is maybe an e-fax number and a fax machine under a trench coat, which I'm here for. Like tell me about AI in a world like this, right? Like what?
Well, and so I share this story just to kind of bring up the point, like what we're focused on really is eliminating that, right? We, through our company work literally billions of pages and do it all electronically and utilize, I'm not going to say AI because I heard you a few weeks ago talk about what AI means. It's really machine learning, right? But in a way that automates that documentation. So literally people could get rid of that paper and we can capture those documents, midstream, electronically, figure out what those documents are and then index it right to the patient. And I mean, that makes a massive difference for clinicians, for those that are administratively working those processes. And I know we always like go back to, well, is it curing cancer? Well, it's certainly making it faster, right? And that's exciting to me.
That is exciting. I'm kind of into that. This is less lame than it could have been, which I'm here for, right? You want to save things.
Don't listen to her, Caleb. No, this is great.
Well, again, we're not talking about curing cancer, but like I think you're right. Like, how do you make the whole process simpler?
That stuff matters.
And
cutting things out.
We appreciate that you're saying like machine learning. Great, cool, okay, but like, what do you actually think of AI?
So I'm going to talk about it in two ways. Is that all right? Like from a marketing standpoint,
it's allowed,
and then a technical standpoint. I was actually thinking about it this morning. Like when a lot of people say AI, what they mean is automation, which means they created a feature that automatically does something. And I'll liken it to this. Like today I made toast and I put the bread in and I pushed the lever down. And then after about a minute, the bread flipped up, right? That was automation, but I don't call that AI. And I think there are too many people in this industry that call AI that, right? Just like
Totally.
simple features. And
the toaster.
Yeah,
the toaster.
Right? But I mean, I think it's the way people talk about it now. They talk about it like in 2 years, it's going to change the world, when really it's probably going to happen in 12.
Mm-hmm. Mm-hmm.
And so like, I think the maturity for the use cases is going to take time. But I think we're going to look back in 2 years and we're going to say nothing was done. Like
I could not agree more, Caleb.
But we're
That's,
gonna look back in 12 years and we're gonna say that's crazy.
wow.
What happened.
Yeah.
Oh my God.
I mean,
I cannot wait.
I agree. Strong agree.
Oh no, Lisa, I'm sorry. I was just thinking about how we could make a toaster with Caleb's face on the toast that pops out of it for the cover for our next show. I'm freaking here for it.
Amazing.
Oh my God. All
Yeah,
right.
I totally
All
agree.
right, Caleb, did you have
Caleb.
one other way to tell us about AI? Because I know we were behind schedule because we couldn't figure out how to use the internet today, but like you had one other analog for AI.
No, I mean, it was really that last point. It's just
The toast was all you needed. Like I'm here for it. The toaster. Oh my God. Oh my God.
There you go.
Yes.
Amazing.
All right. Any parting words?
Yeah, two things. One, I'm a fan of you guys. I love what you're doing, and I'm excited to see you at Vive. I'll be sure to say hi.
Oh yeah, come say hi to us.
Awesome.
We'll be around. If you're really a fan of the show, you could give us a tip so we could buy a second Vimeo license.
Oh,
I don't know.
That's extortion. That is illegal extortion.
I'm still trying to figure out how to do that tip, so just send that over to me.
I also run our website, so there's a possibility I screwed it up. I don't know. Who knows? All right. Tell us. Other than you love us, I know everybody does. Everybody's here. It's amazing. We like blew up the internet. Like, so parting words. What do you want all of America to know about Vine?
Well, I think I've essentially said it. Like and I really, I mean, nerdy, like where's my glasses? But when I look at the unit economics and I look at what it means to really streamline healthcare, like it doesn't come in these big crazy waves, but it comes in this automation that I'm talking about, going from 5 minutes to 5 seconds. But when you're looking across 300,000 orders, right? And you multiply that to the days that it takes and what that could mean as far as overturning denials or decreasing, that heavy lift that our administrators and clinicians have every single day. I mean, I love it. I love waking up and doing that kind of work every single day. So
that's awesome.
We need people to love that. All right. And with that,
totally.
God bless the Great Salt Lake.
Thank you, Caleb.
Thank you for coming on the show. Thank you for being hilarious about the shirt and the walls too. We appreciate some good drama llamas here. So, all right, we'll talk to you soon. Thanks for sharing, Caleb. All right, now we got this girl,
Lauren. Oh my God,
ladies.
Oh my God. Yeah, and just so our fearless audience knows, we started this show a little late because we couldn't figure out how to use the internet, so we're gonna go 10 minutes late. Just FYI, just in case anyone was curious.
We're gonna fix it. We're gonna fix it.
All right, so Lisa, where did we meet Lauren?
Okay, we met Lauren. We literally met her at a party at JPM in San Francisco. I think, as I recall, Kat was walking up and talking to everyone in the room, but it was like a very instant energy match with Lauren, who was ready.
Yeah.
Lauren is also down to clown, just to be clear.
Yeah.
So we're super happy to have you. And you were like basically just sort of unveiling your company to the world. So maybe you introduce yourself and tell us where you are right now. What's going on?
Yeah. Well, thank you. My name is Lauren Adams, and met Lisa and Kat, and was totally fun and really excited to be on the show. So we are actually just coming out into market, and I run a company called Mesh Health Solutions. I'm the CEO and co-founder, and our focus is really on how do we start to automate prior authorization and really cut through some of the pain points that everyone's facing today. So it's really exciting. And we saw that CMS also just finalized the burden reduction rule and prior auth and interoperability rule. So it's a great time for Mesh for sure.
It's a great time. And also, I would just note, you are from Philly. I'm getting that right, yes?
That's correct.
Philly?
Yeah.
Okay, so
Philly, you can feel it.
As everyone knows, Philly is southern New Jersey, and New Jersey is northern Philadelphia / Pennsylvania. So, I mean, that's why there are so many comparisons between our best community manager in the world, Melissa Dinino, and Lauren. We've just learned. And so love the energy, love Philadelphia, and don't want to start any cross-border fights, but you're both awesome.
Yeah, I mean, there's Yeah, the liquor taxes are better in New Jersey, speaking as a
Yeah.
Pennsylvanian. So, hey, okay, listen. So one of the reasons we love Lauren and like, so, like there was the big energy feel and it was into it, but here's Lisa. This is what made Lisa fall in love because Lisa's a little bit more discerning with people than I am. That's why we have to be together because she tells me, Kat, that
Yeah.
is not the right
Yeah.
person to be talking to. But
give her the
with
hug.
Lauren, here's the deal. So Lauren, I think like maybe just whispered prior auth to Lisa. And it
Yeah.
was like, so Lauren, tell us how you feel about this new role. Like what?
Well,
We've talked
you
about the
know,
new rule on the show before, the prior auth and interoperability rule, new rule from CMS, from Alex Muggy and her team at the Office of
Look at
Burden
her.
Reduction.
She can't even freaking help herself.
Great people. I can't.
Oh my God.
I mean, Alex
Yeah,
is
she's done.
awesome, and this role is really helpful.
yes.
Lauren.
I think it's absolutely helpful because pretty much to date, prior auth has just been a pain in the ass for everyone, right? So it creates barriers, along kind of the same themes that we've all been talking about. It delays access or doesn't enable access to care. It's incredibly challenging today. It's a very manual process. I mean, we've seen a lot of innovations around prior auth, but the fact that we see the standard coming is great, but I don't think that's just going to be the silver bullet. Similar to kind of cancer, prior auth is one component during a cancer patient's care journey. And it can also be one of the biggest pain points because it either can block access or it can delay access during a really, really difficult time. And then to Caleb's point, there's a lot of administrative work that goes on behind the scenes, whether you're at the hospital side, whether you're on the hospital provider side, whether you're even the patient or really also on the payer side of the house. A lot of the processes are done manually today, and they're through fragmented and disparate systems. So for Mesh, we're really focused on, where do we apply automation or AI appropriately? We don't believe that, humans in the loop are going to go away, at least not in the near term, but where can we also provide those tools to really help accelerate? So really the goal is to get that access to care, get to those final determinations. So really every member can really get to whatever services or medications or whatever they may need and ensure that, we can really move the industry more towards a UM by exception program where we do have, the machines really doing a lot of the components behind the scenes. And we're really spitting out the information where we need clinical reviewers, where we need human intervention, and really ensuring that efficacy as well.
I love
That's
machines,
awesome.
Lisa. Love them. Love them.
Love them.
I mean, I love when I don't have to think about the mechanics of prior authorization. So I'm a fan of that idea, and I'm sure a lot of people are. I do think it's really interesting. Obviously, all of the threads between all of our guests and topics today around, trying to use, and this is like, as I have mentioned many times, I think the only appropriate use of AI, and I totally agree with Caleb. It's like, what are you talking about? Is it the automation, the spring in the toaster, or is it actually something doing meaningful with data?
I love that.
For me, it's the only reasonable use and expectation of data and automation right now in the next 2 years, right? In the 2-year time horizon plus a little bit more is how can we start to automate some of these horrible, burdensome paper-driven tasks and processes that really just serve to stop and delay and like obfuscate the process towards actually getting care. Because of course, you don't have to be even much of a cynic to know that these tactics are there, these systems are there in order to stop you from getting care. I am hardly a, whatever sort of semi-disparaging comment I can make about certain groups of people. I'm hardly one of those. I'm hardly a Kat McDad conspiracy theorist, but we know it is factual that these are systems put in place to do utilization management and stop people from getting care. And in cancer, as we know, care is expensive, is incredibly burdensome. There are plenty of disease states, but cancer is extremely widespread, extremely burdensome, tons and tons of financial toxicity around it. And these processes we're talking about are part of that, right? Prior auth happens in cancer care. Prior auth happens in a lot of places. In cancer care, for sure, it's a huge cost. And then what you can do to like move these things behind the scenes to get them resolved quickly in an automated fashion is really, really important.
Yeah, and if you think about
so you're
it,
like
Lisa,
in the launch, you just launched.
Yeah, and it's an ecosystem, right? So if we work with CancerX and vendors, right, who are focusing there, there are initiatives going around to standardize and streamline right through FHIR and the Da Vinci Project, but then also working with Vine because they already have a lot of the, they're pulling together the disparate data, right? And so then you have kind of Mesh where we're thinking about what are we doing with the prior authorization? What are those specific data requirements? How do we use automation and AI tools, right, to actually accelerate the process? And that's what it is
Right.
there's a lot of gates and there's a lot of data, right, that needs to be surfaced at the right times and available and surface at the right time, so we can actually speed through the actual decision and enable that care. And with CMS, having the standards coming is great, but kind of look at history repeat itself. Pharmacy had no standards. Now we have script standards. There's still challenges. And so, to me, and really with Mesh, it's really about making sure we connect the right ecosystem and we apply the right technology at the appropriate times. We'll also be laying baselines, so that way we can get more of that historic data for more of those, future innovations to really get there. But, I think that the common theme that I saw, throughout all of the speakers today is, how do we get access to care, right? How do we make sure we streamline it? But then also, how do we also use technology to actually create the right ecosystems, ensure we're accessing care or data at the right points of time? It's all there. And that's what's really sad about this, kind of what's happening pretty much across all the speakers is all of the data is there, but it's really around how do we access it? How do we then leverage it or get it into a machine readable format, right? And then actually share the data across the various stakeholders throughout a patient's care journey. And prior auth tends to be one of those kind of, stop roadblocks that, becomes really painful just across the board. So, and I have cancer survivors in my family as well. So, I've lived that as well, where you're kind of numb and you're trying to just get through what you need to, and then having to deal with administrative crap or, just getting access to the care. And there's a lot of waste, right? So if you're readying a cancer regimen, but you don't have a prior authorization, that could be wasted, and that's not going to, and then the patient may have, downstream or adverse effects because of that. So again, it's really one component, right, through a patient care journey, but we really care about how do we leverage technology to make sure that it's not just about, margins or OpEx, but it's really about streamlining the process and streamlining the data to get to the end determination in a much quicker way than what's happening today.
Yeah, all that is money and time. It's
Yes.
this weird dance that's been happening now, as if we're thinking of all the parties who maybe should be earning less money, they're all doing a dance, the money dance, and whoever, when the music stops and you don't have a seat, then you're out. I guess that's kind of the what's happening here, and that's kind of the game, like chasing the prior auth until I actually am forced to do it and actually forced to pay for it, or vice versa, or you lose out. And I think I think it's a really important part of this overall solution, but it's something that you might not think about first. And I think both of the examples from Vine and from Mesh are just really important things that can be improved significantly behind the scenes. And then, of course, the enabling factor for that is policy, as you all know I love. And I think, this is the kind of thing when those things change. And then, by the way, think about this. This has been multiple years to try and get this rule finalized. This rule was a twinkle in Alex's eye, 5 years ago plus, plus lots of work before that on the various different standards around prior auth. So it's been a long process, and it was actually slowed down because of policy and because of politics. That's really exactly what happened. Literally, most of this rule was finalized in 2021, January, and then rescinded due to the political situation, the changing administration. So that's a couple of years we lost. Huge bummer.
Yeah, it's a load of bullshit. Yeah,
the good
kind
news
of
for
sounds
us is that the technology has evolved at least, right? So while you're absolutely right, there's a lot of time wasted, but the good news for our industry is that the technology has evolved even since the initial proposed rule that went out, and so that actually gives a lot of great opportunity to really start streamlining it. And really, it's about streamlining it in the appropriate ways, and we care very much about what's appropriate now versus kind of what is kind of future thinking. And all the future ideas are great. And I think Caleb said it well, 2 years versus 12 years. I think everyone has a goal of trying to get to that holy grail in 2 years. But the reality is, like I said, when history repeats itself, there have been standards out there. EDI has been out there for decades, right? There were opportunities to streamline this. It just was not widely adopted. There were some gaps in kind of how that was. But now we're moving to different standards, and that's great. So it really is, and kind of to your point, Lisa, it's resource spend on all parties. It's not just the hospital. It's not just the payer. it's also the member, right? And it's also, you know,
Right.
suppliers. It's a lot of folks who are involved to really just move through this process. And that's why it just creates cost, time, and inefficiencies. And we, you know, at Mesh, we just strongly believe that there can be an efficient process to make sure we're gathering the appropriate data, ensuring that quality and cost-effective care. But let's just remove the unnecessary friction behind the scenes, you know, and get people access to their care.
That's awesome.
Yeah. Well, let me ask you this too, because I totally agree with what you're saying. A lot of these processes exist to like deny care, right? Or deny spending money on care. Same thing. I don't know. So who do you think should make less money in healthcare?
Oh, that's a really good question. Who do I think should make less money in healthcare? Well, I think that
Nobody's watching this. It's barely even recorded.
Yeah, no one's
barely
here.
recorded.
Okay, nobody's gonna remember what I say out of this, right?
It's totally cool.
Yeah. You know, I would actually go more on, I think there's probably areas that everyone could make less money in healthcare, right? I think pretty much there's waste across the board. And this is one of the areas that, you know, we can help reduce some of the cost or the waste that's happening. I think that there are a lot of, you know, across the board, when you look at all the sectors in our industry, there's probably lots of pockets of areas where people are getting overpaid and they're under delivering as well. And so I think if we really start to think about those areas and how we can start to either not create or, you know, be paying folks to do things that aren't actually driving care in our industry, I think we would see a big difference in the world.
Yeah. Okay.
I'm hearing
Policy
a pay for
question.
performance.
Okay.
I'm hearing pay for what works. Pay for performance.
Pay for what works. I'm here for
Just
that.
like Heroes.
You know, yeah, just like the Heroes program. Okay, so Lauren, because it's Friday and I know Lisa wants to snuggle up with a glass of wine and think about policy. So talking about the recent final rule with prior auth in there, if there was one thing what is one piece that you are sad is missing from that? Like, what's something that would have been awesome if it was in there and it's not, or it got taken out in the rulemaking process? Like, what do you wish was better in that rule? One thing.
So here's what it is. The rule really addresses the digital pipes, right? What it doesn't necessarily, and it addresses a very small portion of operational efficiencies. So what's missing from my perspective is how do you become more operational effective even when you're opening the floodgates? Because while I appreciate fire standards, being able to share more data in a structured way, in a much quicker way, if you're not prepared from an operational perspective, you may even conflate your current problem. And so for me, and really from my perspective is yes, it's great to have a standard way to communicate about prior auth, as well as getting more structured data. However, what it doesn't fully address is kind of once it lands on a health plan or even a delegated entity, there is nothing really driving that except a 72-hour turnaround. Yes, we should be showing denial reasons. Why are you denying it? There should be a legitimate reason of why you're denying it. But outside of those two primary components, right, there's not much more that rule is really addressing across across really just the general operations of those reviews. And so that's also where, from our perspective at Mesh, it's kind of the two combined, right? If you think about your operations and you think about your digital pipes, you really then start to move to digital workflows and transformative workflows. If you only care about one or the other, you're either conflate one area or the other. And so that's what I would say was missing for me from that current rule is how do we actually also operationally think about more standard operating procedures, making sure, we can actually move through the cases versus just getting the information over quicker.
Nice.
Yeah. Awesome.
Sounds like an implementation guide.
That's right.
Seriously? Like we should make an implementation guide?
They need sub-regulatory guidance from the Office of Burden Reduction.
I don't know. Whenever the federal government says, wow, we made an implementation guide, it's going to solve all your problems, I just go, bleh. So I just threw up a little bit, Lisa, when you said that. But I get what you're saying. We need implementation guidance. That's fine. Okay. As long as it's not like some 400,000 word document made by a bunch of consultants, I'm freaking here for it. I'm here. Maybe Lauren can write it. That would be great.
Yeah, maybe Lauren can write it. It's fine.
Then people can understand it.
Exactly.
Yeah. I agree. A strong agree. Okay, Lauren, big takeaway for our loyal followers.
Yes. Big
What do you
takeaway.
think? Like, what do you want to tell America? They're all watching.
Well, what I want to tell America is prior auth shouldn't be a pain in the ass. And we're really, really working hard to make sure that, it's not a pain in the ass. I mean, that's really what we're focused on is we know that prior auth is not going away, but it does not need to be as big of a pain in the ass as it is today.
Awesome. That's amazing. We are so glad that we met you, Lauren, and we are going to see you at Vive in just a few days. I was just notified by them that it's 10 days away, so that's exciting. Very soon.
That's right.
Yeah, they just sent us an email. We'll be there. You got to come over. We're gonna, we're real media. Like we tricked them into thinking that we're real.
Real media.
We'll be there. We are looking forward to seeing you. And with that, we will send you off. Lisa, any parting words for our world famous? This is a bummer because the show actually was like semi well produced today.
So good. So good. No, amazing theme, amazing speakers, really important stuff. We're gonna fix it in post. We're gonna fix it in post. So you can watch the video.
We might.
Yeah, we might. I'm gonna say, I don't want to say rest in peace to Alexei Navalny because I don't think he's actually a great dude, but Putin murdering his primary rival in prison is unsurprising and also really freaking sad because that dude is terrible. As your grandmother, I believe it was her birthday. Her birthday is today.
Today, Grandma Kay, aka Graham's birthday. And as Graham always told me while she was forcing me to do all kinds of farm work, when I would complain about having to learn how to preserve food and stuff, she'd be like, Catherine, if the Russians come, there won't be any grocery stores. What are you going to do?
There won't be any grocery stores. Exactly.
Yeah. I mean, let's make this slightly political here to our loyal followers who are still with us after our 5:30, definitely not cut off. Maybe we should just switch to video.
And Putin is terrible. Don't be fooled. Alexei Navalny wasn't great, probably anti-Semitic, but also his primary opponent, and he was just murdered in prison. And if the Russians come, there won't be any grocery stores.
If the Russians come, there will be no grocery stores. And if any of you think that we should just let Ukraine go, I'm pretty sure based on the fact that Putin has now killed all of his competition and all of his naysayers, maybe we should be a little bit more supportive of the Ukrainians fighting their way for their country. So go right to your Congress people, write to your senators, write to your president, write to all of them. Be like, listen, Mexico's great. Let's do that later. Let's help Ukraine. Thank you. All right. God bless America.
We took a hard turn there. We took a hard turn there into global politics, but it was important. And, you are amazing. We are going to be, as noted many times, live in Los Angeles, downtown Los Angeles, somewhere. Melissa says booth 1 and 5. I think that's where we're recording.
Sure. He's going to get us there. We're not worried. Yeah,
we're going to do amazing. We're going to have so many technical difficulties, be incredible. But we will see you all soon. And thank you to our amazing guests who really put up with a lot of nonsense this week. And
thank you for getting here.
Thank you, Leslie. That's it. That's all, folks.
Thank you, Leslie.
See you soon.
Caleb. Thank you, Lauren. All right. See y'all later.
Bye-bye.